So, welcome to Berlin, and thanks on behalf of Andreas Ulrich that we have been able to play this today in the program, and we have an outstanding panel. So, I'm really privileged to discuss with you this woman cancer or this cancer aspect at all, because I think there's no doubt that cancer can be a signature disease where we can bring our holistic approach to the patients. I'm Jalit Ziuli, I'm a gyne oncologist from Charité, and we established a woman cancer center focusing on global health initiatives, and I think that can be maybe one of the next aspects we have to discuss, how to bring the roadmap from prevention to treatment to cancer care in all aspects in a quality that we have much more access to the best treatment. There's a high dynamic, but we know not every patient will experience this process, and that's the reason why we invite you to discuss with us, and we want not only to discuss, we want only go to an action. And you are empowered even to be part of this dialogue today.
Thank you, Jalit. My name is Andreas Ulrich. I'm working with Jalit in a clinical department within global perspective. So Charité goes global also from the clinical setting. It just comes out from an operation theater, and we know that knowledge exchange is extremely important. Very much important in the global health agenda is because it's a very competitive environment. HIV, tuberculosis, health systems. We have the privilege to position cancer control as part of an essential element of global health, and we are proud to launch the publication, a Springer edition, which is called Global Health Essential. Please, one slide. Just one slide, and this is what we were launching. We have written a chapter in that. No? First slide, please. No. Yes, Global Health Essentials. So it's a standard procedure of global health, and we have positioned cancer control in this context. And we are launching this because it was published 2 weeks ago. So it's fresh, and I think it's a good complementary thing that not only we talk, but we have something as reference. And within this chapter, we have one map I would like to show. It's a very specific map which is listing the ranking of cancer mortality worldwide, men and women together, in the age group 30 to 69, means where we see the very active population, which is dealing with the dynamic of national economies. Blue means first, ranking first mortality in 55 countries. So you see it's more or less the high-income countries, but when you look at the low and middle-income countries, you have 79 low and middle-income countries where cancer ranks first. Cancer, all 200, 300 cancers together. And then even in Africa, you see quite interesting pattern of cancer where you see there is northern Africa, it ranks second, and even in Central Africa. And then you have other countries where it's less, but the access to care is even more complicated. That's the reason why we have put together this panel and this theme, because it's about access to cancer care worldwide. So it's not just a question of high-income countries, university hospitals, Charité, where you have everything, but it's in terms of equity, we need to think about how to get the knowledge about advancement and knowledge, cutting-edge knowledge, to the place where there is cancer. And cancer is everywhere. So I would like to introduce two of the panelists. Rafaela is on my side. On the left, she is representing the World Health Organization. She works in the unit of global cancer control. She is an oncologist by training and is part of the Lancet Oncology Commission on Cancer Genomics and Precision Making, and precision treatment. She's ESMO member, so she's also part of the leading International Society of Medical Oncology, and she works at WHO since this year. Yeah. Then I would like to present Professor James Dow from Aberdeen. He is the chair of the urologic surgery at the University Hospital of Aberdeen, the first chair, and he wanted to make this very clear, the first chair in the 500 years of history of this university hospital, first chair. And he is founder of Horizons, an innovative social enterprise for sustainable, systemic, and permanent transformation of maternal and infant healthcare in West Africa, because he has roots in Gambia. And he's the co-founder and managing director of the Scottish Urological Cancer Charity. Khalid?
Yes, and it's my pleasure to invite Isabel Mestres-Geneva to our panel. She is the COO at the City Cancer Challenge Foundation in Geneva and born in Barcelona. And Isabel holds an MBA from AZ Business School, and for many years she held the leadership position at the International Union for Cancer Control, the UICC. And cancer service delivery and capacity building are, I think, your main objectives of these contexts, and especially in the context of megacities. And Roxana Ferdinand, welcome. And she is the Vice President and Global Medical Lead for genitourinary cancer drug development at Pfizer. It's even a big place here in Berlin. And she is aiming at bridging ethnic disparities in cancer clinical trials. Originally from Trinidad and Tobago, and she earned her MD at the Imperial College in London and worked in the NHS as a hematologist at St. Bart's, one of the most privileged centers in London, and before she went to Pfizer. So welcome that you come to our invitation, and let's start. Rafaela, how we can increase cooperation for education and training for healthcare providers in cancer care, and how we can make it really feasible worldwide?
Yes, first of all, difficult question. Thanks for inviting us as WHO, and I'm very proud to be here to represent our team. This is a difficult question because we have, I think, two different problems to address. First of all, we have the issue of the shortfall and the workforce and the workforce crisis. We expect a shortfall of 10 million healthcare workers in the coming years. And this is the situation that we are dealing with, and it will increase exponentially in the coming years. So the workforce crisis represents a problem for education and training. Because you have people working in cancer care that needs to be highly skilled. And if you look at the pathway for cancer, so starting from early detection, diagnosis, treatment, surgery, radiotherapy, medical oncologists for systemic treatments and palliative care, you need a well-trained workforce. And how can we increase and cooperate to improve education and training of the workforce if the working load is so high and the people don't have time to attend the programs and to participate in continuous education? So at the same time, we have the increasing burden of cancer. So we expect that the burden of cancer will double in the coming years, and the increased complexity of disease. So how can we combine all these aspects? And this is, I think, the most important question we need to address. Also because the workforce represent the main, the bottleneck of the investment in cancer care. From the WHO data, we have seen that 65% of resources in health systems are absorbed by the workforce. And so we need to carefully plan and optimize the workforce, first of all, and then in parallel, work to increase the education and training, high quality education and training. So we as WHO are helping countries to address these two issues together at the same time, for example. So we are developing, and we developed a tool to help countries in their financial planning on National Cancer Control Plan, in the planning of the workforce. And we are developing a second tool, thanks to the collaboration of the European Society for Medical Oncology, that will provide us with useful information on how to train a high-quality workforce, but in a contextualized manner. So based on the need of specific countries, because we can have several methods and several approaches, like, for example, a standardized curriculum or online training. So we have the means at the moment, but the problem is that what we think medical oncologists or the oncology workforce in general needs to know maybe is not applicable in a local context. So I make you an example of the treatment, systemic treatments for cancer care. We have guidelines for international societies like ESMO, ASCO, and other guidelines. And we are doing amazing workshop and courses and conferences to improve awareness of medical oncology on how to apply the guidelines. But then if you go to local context, you find that what we are advising as treatment, as best treatment, is not available in the countries. So we are teaching something that is not available in the local context.
But that's maybe one topic later, how we can really use guidelines in a global perspective, if we talk about checkpoint inhibitor or whatever, but how realistic is this to bring it in a global scale? So James, what is your answer, how to make really things happen more globally? Because there are wonderful islands of activities, but how we can make a bridge and a structure sustainable approach?
Well, first and foremost, thank you for the kind invitation to be here. I think there's no easy solution, in the sense that I don't think that we as a stakeholder group are committed to this change. Not yet. I think for me, of course, part of my role, albeit I don't spend a lot of my time dealing with women cancers, I spend a lot of my time dealing with urological cancers, prostate, bladder, kidney, testicle, and penile cancers. That in Europe at least is about 30% of all cancers, and globally probably 20% of all cancers. But they don't have that level of awareness in the public compared to women's cancers. The question is why, right? Because these men have daughters, they've got mothers, they've got, and I think we need to change that narrative. I think for me, training, looking at the EAU, I'm in the European Association of Urology, and I'm responsible for the education portfolio, training portfolio. We have 19,000 surgeon members. The challenge we have is, why are we educating our young ones? I don't think we ever sit and think about it long enough. Why are we educating and training young doctors or young surgeons or health professionals? Why? Who is it we should be training? I think we need to focus on that, because if we don't have the right stakeholders, like today I look at this room, I look at this table, amazing people around me. Where are the patients on this table, around this table, right? I'm being self-critical of us here, right? Where are the patients? Where is the voice of the patient? Because finally in healthcare, whatever education training we do doesn't impact us as surgeons directly, impacts patients and their families. Yes, you have me here as a surgeon, but I'm 57 years old. You should all say I don't look it, of course.
That's good now.
I'm 57. My time is almost past, right? Where are the young ones, right? We need the young ones to tell us how they think they should be educated in 10, 15, 20 years' time, right? So being self-critical in a most loving way is just an example of how we are in this ecosystem of healthcare in terms of education and training. We all say we need to train and educate on value-based cancer cure and care. What does that mean? It has to be patient-centered. It has to be evidence-based. It has to be cost-effective. But it has to be driven by data, underpinned by data. Which data? Certainly patient-reported outcome measures. Certainly patient-reported experiences of care measures. Certainly quality of care. I don't think we as surgeons immediately think about what the patient really, really cares about. We think first what we want to do, i.e. cure. If I remove the prostate cancer, patient's cured, I've done my job. Well, no. If the patient is wet, cannot leave home, has to buy pads, which they cannot afford, cannot have erections, cannot have a sexual relationship, have I helped the patient? No, I'm treating a disease. I should be treating a human being with thoughts, with families, with aspirations, with dreams around a little problem that was interrupted for a moment by a thing called cancer. I think we don't have that balance right. But I think if we start by asking why and who we should be training, then we deal with the how, then we focus on how all of that point to these outcomes that not we, patients, their families, society, everyone else desires of us, then maybe we will be better. Maybe we will be better in time for the next generation. I hope so.
I love it that you incorporate all the other relevant, crucial perspectives. So Isabel, what is your idea to make really the next step?
Yeah. So, well, first of all, thank you so much, Andreas, for inviting me to this table. And I also want to congratulate Rafael. I'm really excited that you've joined the WHO cancer team. So I'm very happy for that. So everybody knows what charity does, everybody knows what WHO does, and everybody knows Pfizer, but I don't know if everybody knows City Cancer Challenge Foundation, so allow me to just give a very brief introduction so you can understand then my comments and our experience in the ground. So City Cancer Challenge Foundation was spearheaded by the Union for International Cancer Control to support countries to improve access to cancer care, to actually take those global targets, those national plans into action. In order to drive action, we all know we need that the community has to lead the way. It has to be a bottom-up approach, supported with a top-down. But the reality, and what James was saying, the patients are in the ground, are in the community, and the health workers that are dealing every day at the community level. Cancer is a complex disease. So what it means for us, community, the minimum viable product, that's how I call it. I'm from the business school, so the minimum viable product is a city. In order to address cancer from a comprehensive perspective, from a health system strengthening perspective. The national, it's too complex, but if you take it to a smaller scale, you can actually generate the data, understand what are the gaps, and you can accelerate interventions and accelerate innovation in that context. When we talk about cities, I'm sure most of you are thinking about your mayor and wondering what he has to do with cancer. Maybe very little. He should be definitely focused on prevention. He should be definitely putting a lot of efforts on environmental for the city. But he has also a role to play. But when we talk about cities, it's not just about the mayor. It's the national government. The national government has a say in that territory. The regional government has a say in that territory. So we work multi-layer government, and then we bring all the decision makers that have a say in that territory, despite if they're based in a capital or in another city. So that's where we bring patient organizations, academia, all the hospitals, both public and private, the payers, the institutions, and the government together to understand what are the gaps. And of course, we are assessing all the gaps, all the clinical services situation in that city, but also the management. And that's where it brings the human resources aspects. We also assess the quality and the access, bringing also the patient perspective. So with that introduction, from a human resource perspective, we do a full analysis of what are the gaps. We need to understand what is the issue? Where is the health workforce missing? In which areas? Where are weak? Where they need to be strengthened? We need to understand what are we dealing with. And this is super important for any collaboration. When we're talking about that, we need to start listening more and not thinking that what works in our countries is going to be working in other countries, because it's not. Mm-hmm. It's not. And I'm facing it because I work in LMIC countries and I have very little evidence of what works. There's a lot of evidence of high-income countries that, let me tell you, we're like banging our head trying to use that same models. It doesn't work. Mm-hmm. And we need to start generating evidence of what is required and what type of training they need. It's different type of trainings. Of course, they have to lead the work. They know. They're really very good, incredible health workforce. They're so good. We just need to listen and solve what they need. And of course, we have to involve the international community. We need to involve ESMO, ASCO, the Society of Pathology, IEA. They know what is the up-to-date information. And we need to facilitate those international consultations, but it's a facilitation. But we need to make sure that all the programs that all these professional organizations, university are delivering are all under the same understanding of what are the gaps in the local. So at SICAN, we're thinking about innovative ways of providing training. And I'm going to be, in my own organization, I provided to all the SICAN staff free access to edX, an online platform. How many took it? Very little. People don't make time for training. Exactly. And it's free, and they keep saying, I need more capacity. Well, I gave it to you. You have it. But nobody's taking it because we are not innovating enough on how to deliver training. We have to see now, I am those of that is with the TikTok and the Instagram. We need nanosecond training, nanosecond capsules for capacity development. We need to start partnering with innovation to come up with learnings that are much more attentive, and they have very little time to get trained, so let's nail that attention into what are the key messages. The other thing is more mentorship and twinning programs. That's some of my favorite that we do, and it's cost, but it's so much valuable. And it's bringing the locals, for example, we establish multidisciplinary teams in all the different places we work, and then we take them to other high-income or countries to see how they work. And it's good to see what the super good looks like. But we also take them to other institutions that is one step next, so that they see also what is next for them. But they have to see both, the state of the art, but also what is good. And I have to say that who's learning more are the high-income country institutes that are hosting, because these healthcare workers are so creative. They come so mind, and I can see hospitals from Barcelona, from Germany, asking, we want more of those exchange programs, because they're getting more than what they're giving.
Thank you, Isabel, because edutainment is maybe one option to attract education, because I can remind you that David Sackett, 25 years ago, he said, if you want to be updated in general practice, you have to read 18 articles per day. That's 25 years ago. So let's try to translate it to cancer medicine. And I'm really personally afraid how to catch it. Roxanne, so how we can make it?
Well, first of all, thank you so much for inviting me to this panel, and being here is certainly a real privilege for me. I grew up, as I said, in Trinidad and Tobago, to a father who was a public health doctor and worked with PAHO for 40 years. So it's wonderful to be able to be here, and I lived through, seeing what committed healthcare workers can do for public health. So it's really wonderful to be here. Certainly, I think what we saw in the pandemic is that through international cooperation and collaboration, we really can solve very, very quickly healthcare crises. And really what we need is the coming together of clinical and academic researchers and clinicians together with both from the public and the private sector, so that we can come together and solve some of these issues that we're talking about. And certainly where we've seen some successes have been when we are able to partner in particular with some of these medical societies. We've been talking about ESMO, EAU, etc. And certainly where I'm currently working in neurological cancers, we've partnered, for example, with the Prostate Cancer Foundation and the Pfizer Equity Challenge Awards, where we were able to essentially grant 11 grants across 8 countries, specifically looking at research to understand and overcome disparities in prostate cancer, looking at diagnosis, treatment, and disparities in outcomes, specifically for underserved populations. And where we focused was in Asia, where we have grants in Malaysia and Hong Kong, in Africa, where we have grants in Nigeria, Uganda, Kenya, Tanzania, as well as in the United States, to really be able to tackle this. And I think the important thing was that it wasn't something that came from the top down. These were research and educational events from the countries that really meet their needs, because it needs to be about co-creation. There's no kind of one-size-fits-all, and making sure that we're meeting people where they are and really providing through this cooperation between public and private to make sure that we can really move the needle in terms of health equity, something that I'm very passionate about, and something that we need to really get there, particularly, as you were mentioning, James, in terms of prostate cancer, where we see huge disparities in outcomes for patients. The other point I'd like to make is really just picking up on that kind of patient centricity, because we need to educate healthcare practitioners. Really, the goal is to make sure that we improve outcomes for patients, and that only comes through shared decision making. So if they are left out of that, that doesn't become possible. But the other issue is about making sure that we are improving and really moving the needle on patient health literacy, and how we can make sure the patients are able to be active participants and decision makers in their care. And something as simple as making sure that when patients participate in clinical trials, they are able to access their data. They're able to access the results of these trials in plain language to understand what actually that participation has meant and what the results are. I think is just so important. So I think, hand in hand with improving training as well, needs to also be for healthcare practitioners. It also needs to be how we make sure to include the patient voice, but also make sure that they are also, literate about their condition, about the treatment, so that they can be part of that shared decision making.
Roxanne, so thank you very much. And only one example, we just started 2 years ago, advocates training to do their own clinical trials. It's possible, but we have to start the process. And I was really surprised but impressed by this. I think is the next step.
Absolutely.
Thank you, Jalit. This is a fantastic bridge to the next question. It's about how to increase the knowledge about what is best for treatment, and this is about R&D capacity for cancer treatment. We know that clinical trials are mainly performed in high-income countries, so we need to be more broad, and we have to have a global vision. Cancer is everywhere, and so we need to integrate and to reach out to patients everywhere to include them into new ideas for treatment. And Roxanne, I will take you from there, where you have finished, and continue, because, of course, the private sector is very much involved in clinical trials. And do you think that would be possible to include a group from the Gambia, for example, in your next clinical trial?
So I guess what I'd say is, globally diversified R&D programs from bench to bedside is critical. I think specifically in cancer care, because these patients often don't have a lot of time, being involved in clinical trials is also a way of being able to access innovation as well. So it is really important that this has a truly global footprint. I think the challenges that we face, and it really shows the need to work locally with researchers, with governments, with regulators, to ensure that we have the infrastructure and really sustainability to be able to have regulatory grade clinical trials that have the highest level, obviously, of patient safety and data quality for this to happen. And where we've been able to see great improvements in that is really with these, I would say, regional to local connections that have been being able to be made and bi-directional flow. And certainly about a year ago, we started a project specifically in oncology to identify sites. We're focusing on 2 countries at the moment, in Brazil and in India, to be able to essentially help improve that infrastructure so that we can have essentially centers of excellence, focusing not just on phase 3 trials, but also on early phase trials as well, to be able to do that. So I think it is a big challenge because of the need for kind of regulatory frameworks, but it's one that certainly through cooperation can be done. I think the other big focus that we have, though, because we're talking here about global diversity, is also within the countries and within the sites that we choose to ensure that we also have, a diverse patient population into our clinical trials. And that is, in terms of age, in terms of gender, in terms of ethnicity or race. And there's so many barriers that we know that traditionally underserved populations are not included. And I think together we can overcome some of those barriers. Some of them, certainly from the private sector, are financial. How can we support patients in clinical trials better through simple things like accommodation, transport, loss of income to be able to participate in clinical trials? What we were talking about before, awareness of clinical trials and producing materials so that they can understand clinical trials better and improve that trust with the medical community and with industry as well. And for us, it really started with trying to understand data. So in 2021, we published actually our demographic diversity of clinical trials in BGU. And essentially looked at all of our clinical trials between 2011 and 2020. So these were therapeutic clinical trials as well as pharmacological clinical trials and vaccine clinical trials. So more than 100,000 patients and more than 200 clinical trials. And we use the United States because that's where we have the best data. But essentially, we're able to benchmark essentially where we are in terms of diversity. And this is all also very transparent. Because if you don't know where you are, you can't then fill those gaps. And what we saw was that in some areas, like vaccine trials, and I think we saw those from the COVID studies, actually we were able to have actually quite good diversity based on the demographics of the diseases as well as the epidemiology within the country. However, in cancer, that's where we saw the biggest gap. So, for example, underrepresentation of African Americans, underrepresentation of Native Americans and Latino groups. And cancer actually was some of the worst areas. And for someone who works in prostate cancer or multiple myeloma, which specifically is more common in the African American community, this is a real problem. So we know where the gap is, and we are now, really working hard, having publicly said that we will commit to representation within our studies based either on the epidemiology of the disease or the demographics within the country. So this is a big area of focus for us, and it really starts with, looking at where your sites are. Are there in sites that have a diverse population? And then working at a grassroots level with patient navigators, nurse navigators from the communities. Sometimes it's with religious organizations, etc., to build that trust so that we can actually move the needle. But if we don't have the data, you don't know what to do, but also you can't measure whether you've had any improvements.
Thank you very much. This is absolutely fantastic transition to Isabel, thinking about the context where research happens and probably with your approach. How many megacities are in your group?
We don't call them megacities. For us, it's a city over 1 million to make it
Berlin.
the investment enough for that population. So we're in 14 cities.
14 cities.
And actually, I'm very pleased. I've just informed others that we're opening a new call for applications for new cities to applying. So if anybody has any specific interest for a city, please let me
Berlin?
know. No, it has to be lower big countries.
Underserved population.
So if we go for research, SICAN has been an initiative very, startup mode. We've been just doing and making things happen. We've not been thinking of research from the beginning, but now 5 years later, now that we're seeing results, now we're seeing outcomes, now we're like, oh, okay, maybe we should start embedding implementation research on what we do so we can start transferring and scaling up all the know-how, everything we're learning in those cities to become a global good. So that's a new journey we're getting into implementation research. So I'm going to talk about that, but I think it relates a lot with more of a traditional clinical research. Which is there is no local capacity. There is let's say there is capacity. There very limited capacity. There is no data collection system. There is no research infrastructure. So there has to be two things, I think. There has to be a commitment that we want this to happen, and there has to be patience. And the patient is the biggest thing that is missing today for me in global health, specifically when the more of like the donors are pushing for the agenda and expecting that things happen very quickly. But things are not going to happen quickly because the things are not there. So we have to invest on building the capacity for research. We need to train the locals on how to drive research, and then so that they can drive it. Because if not, what end up is that you end up partnering with high-income institute to drive most of it, and all the most let's put it interesting jobs are done by the partner in that, because they have to sign that there has to be somebody from LMIC in the publication. And I get a lot of people like, oh, do you know anybody there that can sign this publication? And I'm like always debating, like, really? But then I want to support the local people so that they have publications. But at the end, it's just like putting the name. Really sorry to put it out there, but I'm seeing that all the time. So we need to start building the local capacity. There has to be a commitment. We at SICAN, we have a partnership with the Tata Memorial Hospital. They have a Credo. It's a very interesting training program for a clinical trial. We're not in that area, but we've been investing a lot of fellows. And now we're going to be investing a lot of capacity on implementation research. That's something that is critical. The other thing is the funding, again, and it's going back to the donors. Without patient, what happened is that, at least at SICAN, when we have these short-term commitments from the donors, because of lack of patients, we end up hiring consultants to do the work. And that's not sustainable. That's why I always tell to our donors, our partner, we need long-term commitments. It takes time and patience. If we want this to be sustainable, it has to be locally led. And locally led means that sometimes it's going to be accelerated, sometimes it's going to be slow, but it's not the times of the donors. It has to be the time of the local stakeholders. And of course, I'm always that there has to be collaborations between high-income or more advanced academia, research institutes with the low, but they have to be the ones driving. The other ones have to be there supporting the change. And the last thing, and I move, is and I take it from an implementation science. I don't know about research because there's a lot of safetyness aspects there. But the requirements, it's impossible to meet those requirements. Like really, like the high income, like NCI US, incredible. But the people are reviewing that, are thinking from a super high-income country perspective, and then there's no way anyone from low-income country will ever succeed on that grant. And I keep saying, can we just ask them to write in a paper the idea, the concept, the question they want to answer, and then let's help them to make that, or you lower a bit your expectations on what good looks like for a grant application, or you're not going to get grant applications. So it's like, or we support them, or lower your expectations. I mean, at least for implementation science, but because it's impossible. That's my experience.
Thank you very much. This is very much in our, let's say, spirit to think about the cooperation and understanding what is the context. And this is that's like the value of your initiative, the City Cancer Channels, brings to our attention knowledge about the context where cancer prevention and control happens and what is needed there. So it's not about only cutting-edge treatment, but it's only increasing knowledge about implementation side. James, how do you see this relationship between clinical trials and implementation science? There's something where we need to work on.
One of many things I suppose we need to work on.
Yes.
I suppose some of what we're discussing is quite depressing, actually. I'm a happy person generally, even though I'm a surgeon. But I think that, but these are the realities, and we shouldn't be here today talking about nice things that are unrealistic, right? And I think that one of the biggest challenges before we talk about trials, I think that we don't even know what is the true cancer burden in the global south.
Yeah.
We don't. This is 2023. We can go to the moon, but we can't tell how many people have prostate cancer in the Gambia. We can't. You pick any other country, low-income country, tell them, show me your data. They don't have it.
There is no.
Yeah,
Okay.
the registry.
But we can go to the moon, right? So my point is, we're not committed enough, right? We sitting here on this side, and I'm from the global south. I go there 6 times a year, paid for by myself, because I know the least I can do is to show up, right? Is to show up. But I think that we have IAC that is already doing a great bit of work in places like the Gambia, building cancer registries. I think for us to be able to talk about trials, we should at least be confident about cancer burden in terms of robust disease stratification. At entry into any trial, into any registry, we need to be able to define who the patient is, the patient characteristic, stratify them, including ethnicity, ancestry. These are things in the West, it's taboo to ask, am I black? Well, I am black. I mean, people write worse things on Facebook, right, than asking me if I'm black or if I'm from West Africa. But these are important things that actually add to the disparities we see in cancer care. Because when we don't ask, we know that people that have West African ancestry, even if you live in the US, in Florida, we know Hispanics that have West African ancestry have worse lethal prostate cancer disease, right? You're never going to know that if you don't collect the data. So let's put all our political correctness to one side. I mean, we're happy killing people, but we're not happy asking where you're from. What is that? I mean, that is not medicine. It's not a medicine that I came into for. Certainly isn't. Genetic profiling is the other thing. Right, if you have something to hide, fine. Go sit somewhere else. But let the rest of us do our genetic profiles. It's the only way in time that we can understand true disease stratification. Genetic profiling. Why not? Let's do it. We talk about personalized care. We cannot do that without truly committing to understanding our genome. We must build prospective registries, even in the poorest country, low-income countries. It is feasible. Why? Because we can go to the moon. We can do anything if we choose to do it. Yes, we need local governments in those countries to commit, and we must hold them to account. It is their people. They are the leaders of those countries, my country and others in Africa. They need to commit to these things. We can buy Pajeros. We can travel to Brussels for meetings. Certainly we can commit to building a registry that registers who has prostate cancer in our countries, in low-income countries, and other cancers. When it comes to trials, I'm a great believer, having come from Cochrane. I was coordinating editor within Cochrane for many years, where anything else but a trial is like the Antichrist. But I have seen the light. I have seen the light. That it's not just about randomized trials. They have their place. They are the ultimate gold standard. But we know that many other subgroups are left behind. Low-income country people, ethnic minorities, the obese, people on multiple drug therapy, multiple comorbidities. Well, 60% of Scotland will not be in any trial, right? We're blessed with obesity, okay? But these are things that we can learn in real-world data if we care to capture that data. It is complementary. It is not trial versus real-world evidence. The two bring different things to the table, and we can learn from that. And then we must leverage technology. Big data, AI, clinical decision support tools, because if we don't do that, implementation science will take 5 other generations, right? We need to be able to map variations in practice. You know, I sat in a grant awarding body, UK government funded. We used to give hundreds of millions.
Not
right?
anymore.
Not anymore. But I will say this provocatively. if we were to stop giving funding for new research just for 1 year, and we use all the billions to just implement better what we know works, and stop treatments that are harmful to patients, let's just do that for a year. The amount of gain we'll have will be phenomenal. And I think the future generations, I was not trained like that, but the next generation of young surgeons need to be trained differently. Yes, they should be amazing surgeons that can cut cancers out, but we should train them to lead with love and compassion, with integrity, understanding, valuing patient engagement, understanding that it's important to map what you do, collect the data about your practice, change based on feedback you get from patients and others. We should train people differently, completely differently. Otherwise, we'll be here till we die, nothing will change. And that's just not good enough.
Thank you very much. Very much appreciate. This is not only provocative, it's creative what you're doing, and it's
well, the worst you can do is
for brain.
The worst you can do is not invite me back.
No, we will continue. Rafaela, what can WHO do to let's say, encourage clinical trials? There is a program of WHO on registry of clinical trials, and do you see an opportunity from a global governmental perspective, intergovernmental perspective, to let's say, support that?
Yes, so I agree with everyone, with everything that has been said so far, and the discussion is really interesting. So congratulations for your thoughts and your ideas. So regarding WHO position, I don't know if you are aware about the resolution passed in 2022, sorry. So basically, member states gave WHO the mandate to strengthen clinical trials network. So there is a resolution, so speaking about commitment, a resolution on clinical trials to provide high-quality evidence on health interventions and to improve research quality and coordination. So after the resolution, and in response to the resolution, WHO started a global initiative on clinical trials to develop best practice guidance addressing key scientific and ethical consideration on the design and implementation of clinical trials, to strengthen the clinical trials ecosystem, and to address the issue of including in clinical trials the underserved population. So in the past months, there has been a discussion between WHO HQ, because the clinical trials initiative is driven by the science division at WHO HQ. So there was a consultation with regional offices and country offices. And then based on the discussion, there was an open consultation where multiple stakeholders could express their opinion. So for example, I know that the ESMO provides a response and their opinion with regards to the documentation and to the guidance provided. And next month, at the end of November, there will be another in-person consultation and meeting in Geneva. To discuss how to make progress and how to develop best practice guidance to address the specific needs in the local context. So in this big context, we as a cancer team are doing a parallel study on cancer clinical trials. So we just finished the global mapping of cancer clinical trials by using the ICTRP, which is the International Trials Registry platform that is run at WHO. It includes 24 different trials registries, so it's really the broader and the biggest available platform for clinical trials. And we selected cancer clinical trials, and we run an analysis on more than 100,000 cancer clinical trials. So talking about diversity, the situation is really depressive. So we divided, I don't want to tell you about everything, but we aim to publish the results in the coming months. But the results is that basically everything we know about cancer biology, and cancer treatments was developed by studying only white
And
patients
And
in
men.
high-income
And men,
countries. Yeah, and yes. And then this means that when we try to give guidance and to bring expensive treatments in low and lower middle income countries or to diverse ethnic groups, we don't know if the treatments can work, the same treatment can work in diverse populations. So we need data from diverse population, and we need implementation research to understand if what works in the white population works in diverse ethnicities. And then we did a lot of secondary objective researches, and we aim to give a sort of guidance on how to do and what to do as next steps. But we need collaboration, private and public partnership, industry, cancer societies, civil society. Isabel, I think that your model can be a wonderful model to strengthen clinical trust networks in the cities. And so, yes, if we are interested to know more about that, you can ask me questions.
Thank you very much. I hand over to Jalit.
Yeah, thank you very much. And I love it. First, the real-world data story, because this is missing in all clinical trial registries. And I'm proud in our Women Cancer Center, we just introduced a gynecology professorship with a focus on real-world data, because even in Germany, no real-world data registry is available, and all patients in Germany are German. It's crazy.
Yes.
And we're talking about personalized medicine. And so this is really something what we take over. And so we intending next year in Barcelona for women cancer to do a consensus conference, how to describe ethnicity, diversity, and what you said, even based on the emotional conflict. But we have to figure out and to define a minimal data set. It's maybe different approaches. Maybe every patient can define themselves how to describe their personality, but we have to demask the harmonized patient population. And only to remind you, Declaration Helsinki is our backbone, but it's our responsibility to make trials for the global community, and we are not doing this. We're doing this for a specific group. So I know it's difficult, but I apologize to ask you another very difficult question. So how to incentivize stakeholders independent from their individual own pipeline
Yeah.
to bring this to the healthcare system?
So I think that the main problem is how to incentivize countries and governments. So how can we stimulate political will, first of all, because we need resources. But at the same time, we have dysfunctional health systems in low and lower middle income countries. So how can we put money in research context if they don't have money for basic diagnostic treatments? So this is my first comment. But in parallel, how can we incentivize stakeholders? I think that we need to cooperate, not to duplicate efforts and to synergize, because there are many interesting initiatives, but there are separate initiatives. So if we were able to put everyone together and to have a common agenda and common goals, instead of having separate initiatives and silos, I think that we could make a lot of progress. And I don't know the answer, but I think that as WHO, we can have an important role in driving this collaboration, because we have three different objectives. So normative guidance and leadership and country support. So leadership, it also means put everyone together on the same table and discuss openly and in a democratic way.
James, I love your provocate thesis, stopping clinical trials for half a year maybe. How we can make it.
Well, I mean, I think incentives.
Use the money.
I think the incentive side, we may smile about it, but it's critical. And I think we should look at it from both a monetary and a non-monetary incentive. I like the thoughts of Rafael about having, us creating, like we're trying to do with the European funded big data programs, where we have a neutral platform where you have physicians, you have patients, you have industry, you have the tech companies, SMEs and others, all come to the platform. We try to leave all our individual company hats at the door, come in to the neutral platform and discuss things that will change for the greater good. We have to accept that each of us have our own agenda and our own interests and our own corporate asks when we go back home. And so we need to be willing to listen to what each stakeholder needs for their own stakeholder base. If we understand what somebody really wants and we try and find a way of giving them even some of it, you'd be surprised how it doesn't take much to motivate them to participate. But we're not good at listening. We're not good at listening, that's the first thing. The other thing I would say is, in terms of patients, the biggest incentive in my 32 years as a doctor or a surgeon, the biggest incentive patients want from us is for them to feel we care. That's it, that we really care for them. I've never asked a single patient to participate in a trial or a study, and they've said no, right? Why? Because if they believe your study is not even going to help them, but it's going to help somebody else like them, 99% of them will say yes. And so I think we don't spend enough time understanding what are the win-wins for people. And I think for these collaborations like we have with Pfizer in Optima, and my co-lead, Hagen, having been on a very long holiday, is back today for the first day. I've been working. He's been on a holiday, by the way. This is how it works. But he's a good man. We have found a way. We have found a way to cooperate, right? To cooperate, to understand each other, to make sure we understand the other partners in the consortium of 37 different organizations. Without that understanding, nothing works. But if you can have the heart to listen to what Isabel wants or what Roxanne wants, understand it, try and give it to them in an ethical way, anything is possible.
You're totally right. We did a study even in Germany about who doing clinical trials and who not. And the most relevant barrier have been the doctor by themselves.
Correct.
That were not the patient. So doctors are generally not delegate even structures. And this, I think, what we need, the pressure.
You know why? Sorry, we don't have time. We usually have 15 minutes for seeing a patient as a follow-up visit and half an hour for first assessment. It takes more than 1 hour to see a patient for a clinical trial, and the bureaucratic load is huge. So this is the reason there are many barriers to clinical trials if we talk in high-income countries, and the list is really endless. But one of the major problems is that we don't have time.
You're right, but there never be a time where doctors have time. But I think it's very important that we be honest, that we have deficiency in bringing patient into trials and bringing patient into innovation. They are sometimes based on resources, sometimes based on attitudes, and sometimes about nobody take care on this. So, but nevertheless, it's very relevant to look on this. Isabel, what is your idea?
Yeah, I'm going to go with James, because I keep saying is that the listening is and feeling taken care is just, it seems so obvious. But I give you an example, which is just, it's very obvious, but it still is common sense, but still we don't do it. So we work in Kumasi, one of the cities in Ghana, and we got a grant from the German government to improve diagnostic care across Kumasi. So what we did is, of course, we've collected data, we understand where are the gaps, but we wanted to accelerate innovation. Okay, so how incentivize locals to accelerate innovation? So we brought together all the different technicians, people working in the labs, in imaging diagnostic, laboratory diagnostic, and we did a call for German companies, startups, also local businesses from Ghana, local startups from Ghana, to listen directly. What are their challenges? And it was, we call it like a co-creation sprint. But at the end of the day, it was about listening to them. I mean, what is your challenge? What are you facing? And then in that conversation, then suddenly some innovation came as suggested solutions. And because they were part of the process, they've never been in this part of conversations. Suddenly, in that conversation, it came up with standardized pathology reporting across the labs in Kumasi, and we've set up a lab network across the city because, of course, some labs are overutilized, others are empty, and sometimes maybe people are just considering one lab, but no, we should consider the city because it's the ecosystem that flows. So now we're setting up a network of labs to increase the quality of across the labs, but also connect the fluid or the flow of the patients to maximize the available resources. And that's, as simple as listening and they feeling part that they're also developing the solution. It's one of the incentives that we've seen the more. The other thing is seeing the results. And sometimes, it's hard because we mobilize SICAN around 350 stakeholders per city, and they all have to be heard, listen, and they all have their institutional interests and they all have their personal interests. And managing egos and personal interests is always a challenging thing. But it's important that we manage that because they're part of the system, and we have to make sure that as much as possible people are responding. And of course, money is always on the table, specific. And I'm going to put it out there. There's some countries that are very demanding on like, I don't do this if I don't get paid. Other countries that they've never got any attention from any development agencies, they just don't ask for money because they don't know they can ask for money. So at the end, it's like how we listen to them, okay, how we can bring them, because we don't have as much funding. So how we bring them training, how we incentivize with the capacity development, having to connect it with other institutions, with other academic institutions from other countries. That's the value or the incentive we bring. If you get into that, you're going to have the opportunity to bring your career to the next step. The other thing is the public-private partnerships. Innovation is a high risk for governments, and what we're exploring a lot and deploying a lot is the PPPs. That again sounds as very common sense, but there's a lot of policy barriers for that, and there's a lot of unknown and resistance sometimes. But I think COVID helped us a lot, and we're seeing more and more crossing system, public-private services, and being much more efficient. But once you convince somebody, you start at the city level, and then you take that evidence to the government, then things have shifting. But you need to be the one actually breaking the rules before getting the evidence.
But this maybe sounds very simple, but to make competence visible and responsibility visible, I think this is something what is missing in all the project, because some people in a nice office thinking this can be maybe the rescue team, without asking the target population or the stakeholders from the local environment. So
can I react to that, Delid? And I think that we always miss, that Roxanne, is that it's about like somebody sitting in Geneva. I mean, that also puts me on my nerves. It's not about starting meeting in Geneva. Actually, they are the ones driving the change, and they're the ones that have to be setting the agenda. And if they don't want to do it, then let's not do it. But it's important, the ownership. If there is no ownership, if there's not willingness from them, it's not going to be sustainable. And we should not force change if they don't want change.
Yeah, I agree.
Absolutely. Roxanne.
So, I think the question is very provocative because it talks about innovative cancer care. And I think it's easy, often we just immediately move to, a therapeutic, but actually we need to be a bit more holistic around that, because it's really about, our understanding of, through a lot of the research that has happened, is really our understanding of tumor biology. And that has really allowed us to make, huge inroads in some cancers, in gynecological cancers, if you think of prevention with, in cervical cancer, with the HPV, with vaccination, for example, but also in screening, in diagnosis and early detection, and something that's really important, I think, in terms of biomarker testing. Because what we've been able to understand is that, lung cancer is not just lung cancer. It is this small cell, non-small cell lung cancer, is it ALK-driven or is it EGFR-driven? And what that allows us to do is to really identify the patients that are likely to benefit the most. And in so doing, really bring value to patients and to the healthcare system through that. And the issue then is in the real world is how can we ensure that biomarker testing, for example, is able to actually happen. And it really requires, working not just with medical oncologists or with regulators or governments, but with pathologists, with surgeons, to make sure that is actually happening on the ground. Because you can do drug donation, but if you're donating medicines and you can't actually have the patients diagnosed, you haven't really been able to do anything. And so where we've seen some successes is, in this partnership. So as I said, I'm a hematologist and working in chronic myeloid leukemia. We were able to do partnerships, and these are very complicated because it's with multiple groups, but working with ICMLF, which is the ICML Foundation, and they essentially had a huge program with multi-company sponsored to increase BCR-able testing in middle and low-income countries, and providing machines at low cost to be able to do this, sort of $10 US a test. And then we worked with the Max Foundation, which has local access solutions on the ground, and do drug donations through the Max Foundation in low and middle income countries. And so, being able to do that, we were able to have a much more holistic, approach to being able to give access to patients. Because I think too often it's sort of just very simplistic in terms of how to solve this, but actually there were many different steps that were needed in terms of diagnosis, in terms of biomarker, and then you're essentially giving medicines that turn a lethal cancer into a chronic disease if you're giving to the right patient. So I think there's often a question of, well, we can't even get chemotherapy, but I think part of the issue with chemo is that it often doesn't work in a large majority of patients. So if we can really embed precision medicine and show the value that we can bring, because actually you are selecting the patients who benefit the most, and then help with things like biomarker testing and make sure we embed that as part of the system, then we can make really huge steps forward. And I think that's a really important part of where we need to focus in terms of this public-private partnership, to make sure that we can really move the needle. And because it's not a case that this should be, these sort of treatments in precision medicine should not be afforded in low and middle income countries. So I think that's really important. The other thing I want to pick up on is real world data, because in clinical trials we're showing essentially efficacy, but effectiveness is what we get from real world data. And for patients, that is incredibly important. So endpoints like, what is my time to next therapy, is really important if you're a patient, to know how long can I be maybe treatment free? How long is it likely until my disease is going to progress? And that's the sort of information we get from real world data. But being able to utilize that data from these data lakes we're trying to create and use that to show value is really, really difficult, because usually the only thing that's accepted are gold standard Cochrane, phase 3 clinical trials. So I think being able to show the value of this with huge data sets, utilizing patients that would never have made it into clinical trials, and using that as well for decision making, I think is going to be really, really important. And hopefully, working with the European Commission across, as we said, multiple stakeholders, we'll be able to move that forward as well.
Yes, thank you, Roxana. I have a comment and a question for you. I am biased because I truly believe in the power of precision oncology, and I am currently chairing a Lancet Oncology Commission in Canceromics and Precision Oncology, where it's a big project of implementation research, where we will try to understand the barriers to access to precision oncology, so biomarker testing and access to drugs, and those are related to data harmonization, data collection, and international data sharing. So I am the one who really believes in implementation of effective and sustainable precision oncology. But at the same time, we must be realistic about what happened at the country level, because the major barrier to access to biomarker testing and precision cancer treatments in low and lower middle income countries is the cost of the drugs. So we did, as WHO, a survey, so a global survey at the country level of inclusion of cancer services in health benefit packages, meaning that services available without paying out of pocket for the services. And we saw that for the precision cancer treatment included in the list of essential medicine, so treatments that should be available for everyone, and there are only 3 target therapies for lung cancer approved as a class of drugs: erlotinib, afatinib, and gefitinib, and trastuzumab for HER2 breast cancer. So we don't have many target therapies included in the EML. But when you look at the country level, these treatments are not available in low and lower middle income countries, so they don't have access to them, and the reason is a prohibitive cost. So how can we solve this big issue, and how can industry help us as a community address this issue of high cost of target therapies? What do you think?
So, I mean, I guess what I'd say is, it's really about trying to demonstrate better the value of medicines. And I think there's no one magic bullet. If there is, please someone say. But, it's really about taking a multi-pronged, I would say, effect where we, as I said, try to demonstrate better the value of medicines using things like real-world data. But also, in some cases, the World Health Association recently launched the ATOM Coalition. So that's the Access to Oncology Medicines Coalition, which is, multiple stakeholders really looking to share best practice to see how we can innovate in terms of finding, better affordability as well as accessibility to medicines, across industry and across specific to oncology, recognizing some of the the difficulties that we're facing. We also have, as I said, working on the ground, I would say in low and middle income countries for drug donations where this is appropriate, through groups like the Max Foundation who have access solutions, but really trying to build the infrastructure to make sure that actually we're able to get these drugs to the patients that need it, because the last thing we want to do is be donating drugs and then patients, for example, who do not have the mutations that would benefit, end up essentially getting toxicity without any efficacy. And then finally, in 2022, we did launch the Accord for a Healthier World, and that was announced in 2022, and the idea is to really close the health equity gap for 1.2 billion people in 45 different countries. And the focus there is really about specifically gaining access to our entire portfolio of medicines. Secondly, working on access solutions. So how can we build the infrastructure within these 45 countries to be able to actually access the medicines? And then finally, trying to support patients throughout the patient journey. So that's a very ambitious project. It was launched in 22 at Davos to try and address some of the issues that you're talking about. But it's not simple. We certainly feel that we have an important role to play. And, I think hopefully we'll be seeing significant progress.
Thank you very much. We have fantastic speakers. And we have the ingredients now for some time to ask questions and to bring this into the discussion of all of you, how to increase access. And I have a lot of questions. First, please.
Set up the ground.
1, 2, 3,
Hi.
4, 5.
Can you hear me?
Yes.
Okay, hi. My name is Aime. I'm an oncology and palliative care nurse from Mexico. So I don't mean to be petty, but first of all, I would like to suggest that in the future, nurses are considered for panels of discussion of this kind. I'm not going to expand about, why we're essential to achieving better cancer care for patients, but I have a question about prevention. So we mentioned in the beginning, or you mentioned in the beginning, that cancer is actually one of the first causes of death worldwide. So how can we effectively integrate, or what actions should be taken to integrate primary care nurses and advanced practice nurses into the global care roadmap, especially focusing on enhancing cancer screening and or early detection and prevention initiatives? Thank you.
I think it's Isabel's turn.
Well, first of all, I think you are the most important, I think nurses are the most important community for cancer patients in low-income countries, and you should definitely be in this panel speaking because you're the front line. And I just admire so much the work that the nurses are doing in oncology. And for us at City Cancer Challenge, one of the biggest, more important thing is to make sure that the nurses are representing in the multidisciplinary team. Normally, they're not invited into that group, and they have to be in that group. The nurses are critical in the patient navigation, and the patient navigation is a critical aspect for good outcomes. The time from diagnostic to treatment is critical, and nurses play critical role in reducing those time and supporting the patient to navigate throughout that system. And the last thing I want to do is that one of the things I always call is we need to train leadership skills in nurses, because they need to scale in the leadership, in the decision-making table, because they are, as we were saying, they're the closest to the patient. They know best.
Okay, thank you. Next, closer to us. Please, yeah. Okay.
Hi, I am Ali Tinasli, CEO of Lifespan. So we are conducting trials by looking at the metabolic. Thanks. So we are conducting clinical trials in, for example, lung cancer treatment, where we perform a metabolic profile of the patient who responds to the drug. Because I think there have been good points about we don't necessarily need new stuff, but we have to be smart about how to administrate existing solutions. And most important, I think, is to measure in a standardized and precise fashion the response of the patient to a specific treatment. There's a lot of detail which I don't want to mention here, but the question is how to get this into standard of care, because there are many opportunities to save money, and that's, I think, the key point, how to accelerate adoption of innovation driven by AI.
James, would you like to make a comment on that? Yeah.
A straightforward solution clearly is a pathway to guidelines. That's first. But we know that even when you do get your innovation into the guideline, doesn't necessarily mean that people adhere to the recommendations, right? We know there's a major gap between high quality recommendations that are underpinned by undisputable evidence, and you go to the front line and it's not being implemented, right? But I think this is something that needs to change, because the piecemeal way of trying to bring innovation in is problematic, because sometimes harmful innovations come in and stop good innovations from being in that terrain. So I think it's a conversation that needs to happen, but one where implementation science, we joke about it, but it's something that we need to figure out, because if we don't, great benefits like what you're talking about will never see the light that it should see, actually.
Okay, next. You introduce yourself. And
I am Jörg Heiler here from the Comprehensive Cancer Center here in Hanover in Germany.
Okay.
I fully agree with the entire discussion, but actually more or less you had only one perspective, the perspective of the providers. I want to flip the coin, because we know that acceptance of everything, of innovation, of treatment, of care, acceptance is a huge problem, and not only in low and middle income countries. In Germany, we have the screening programs available. Everything is in place. And Professor Zahul knows better than I do is the exact numbers. The maximum that we reach, the maximum is 60% of the population that is entitled to use these things, the maximum. The average is below 50% of the population is accepting the screening programs. In low and middle income countries, it's even lower. And just talking about this is just an education problem or this is just socioeconomic, it's too easy. We have no idea about the complex issues regarding the acceptance of what we are talking about right now. So I think, and it's more a comment than a question, we have a strong demand to understand the acceptance and all these related issues, how to bring the treatment, the diagnostic and everything to the population that needs it most. And especially the vulnerable populations are really in request of this type of research, of understanding, of adapting our ways to provide the care.
Thank you. Charlie?
So, no, thank you very much to remind this topic. And this is something maybe we can even learn from the global perspective. Every program in prevention, cardiovascular disease, cancer, at the end of the day, it's always the same code. What's about the specific program for breast cancer, cervical cancer, colon cancer? Why they are so separated in their programs? Why not to see a holistic approach, especially if you have limited resources, and to bring the programs together? And this is something maybe we can maybe try to change, because at the moment, again, you do your huge program if it's funded for colon cancer screening, and next year it's ending, and then you start with a new program. And where are the umbrella activities? Where are the capacity building? So I love it, and I think even our program should be modified.
Okay. A lot of other questions. So
Last line.
last we come. Yeah. There's somebody. I don't. Yeah.
Just choose one.
This direction. Yeah.
one hand.
Stay up. Yeah. Alois. Yeah. From the development point
Thank
of
you
view.
very much.
Yeah.
Is it working? You hear me?
Okay. We can.
So my name is Alois Dörlemann. I'm a public health consultant expert, and my main topic is health system strengthening. Today in the morning, I was a panel member in the discussion about public-private partnerships. We had that topic a little bit, but I'm also a systems thinker, and I'm convinced without any system, functioning system, nothing works. So my idea is just to contribute with some information. So the BMZ, our German development ministry or Ministry for International Cooperation and Development, they're promoting hospital partnerships. I could imagine, sometimes they work, sometimes not. But I think it could be a long-lasting partnership where something is built in specific countries where partners do understand themselves. Another thing is to support the system via public-private partnerships. Other investments are coming in. If the public money doesn't really be enough to develop, for example, diagnostic and treatment services for cancer in low-income countries.
Thank you very much, Alois. The hospital partnership program is nice. It is good to show that there are 400, 500 partnerships, but there is no really systemic thinking behind the hospital partnership program. So I think we have to evaluate where we stand with this program and what could be done better. And it is, from my perception, a project. It's not a systemic thinking about improving within a country the capacity for research and for treatment and to bring it to the community. I would love to have a dialogue also with the GIZ and I'd say, look, what could be done better? And all you experts could be involved in that review of this program, in particular the City Cancer Challenge, James, WHO, the private sector. We need to rethink the hospital partnership program in a more structured way and focused on gaps. there are many other questions around. Yes, you were so quick now, and you get a phone, a mic which works. The first,
Hello.
I hope it works. Huh?
Hello, yeah.
Yes, it works.
So,
Yeah.
no, I was just reflecting on the title.
Could you just introduce
yes,
yourself?
Esteban Burrone, Medicines Patent Pool, MPP. So just reflecting on the title, fast access to innovative cancer treatments. So you have new treatments, can we get them rapidly to the people who need them? That's my way of reading them. And I heard a lot from the audience about how that's really challenging, and it's not actually happening today in many low and middle income countries. The new treatments are not there. But what's interesting is that in other disease areas, this has been possible. And you have, within very few years, new treatments becoming available at affordable prices in low and middle income countries quite widely. A good example, which is very relevant to cancer, hepatitis C. Hepatitis C, you had groundbreaking treatments coming to market that could cure hepatitis C within 12 weeks. As you know, hepatitis C, key treatment to prevent liver cancer. Within just a few years, 3 years, you had multiple affordable versions available in low and middle income countries. Now, it didn't mean that that immediately became available to people who needed it. But the moment the treatments were there and were affordable, then governments had to start thinking, well, how do we find the people? How do we go and actually screen and diagnose and find the people who can take this treatment? And not all countries did that, of course, but it kind of reversed the dynamic. You have the treatments, they're here. Now, what do we do with them? And some countries, Rwanda, Egypt, there's many other examples, went all the way and then started massively treating hepatitis C. And you can treat and cure hepatitis C today in over 100 low and middle income countries for under $100, 12 weeks cure. So it is possible. It can be done. Yeah. And we shouldn't just accept that the availability is not there or the affordability should not be there. It can be there. That doesn't mean that it solves everything else. And I fully agree with Roxanne that you have to think holistically about access, and it's not just about throwing the treatment in a vacuum. But it is, there are good examples, and it can be done. Thank you.
Thank you very much. I think this is a very important question and let's say, encouragement to think about across the silo of cancer control planning. And Raffaele, probably you could talk about the colleagues in hepatitis and how this worked out in the WHO programs, where you have cross-cutting
collaboration, cross-cutting, and systemic approach. So thanks for your comment, and I really like the idea of leveraging on what has been done in other diseases. You mentioned HCV, but also what has been done in HIV. So successful models, how can we learn from them, and how can we adapt them to the country, to cancer context? What can you please let us know, because I think that many of us don't know, many of the audience don't know how MPP is helping access to drugs at a country level, how MPP is working to improve access to medications.
Yes, sorry, thank you.
You have an important role.
Well, no, I mean, the way we operate is we partner with innovative pharmaceutical companies that have developed new treatments and seek licensing agreements that enable quality afford generics to come in for a subset of countries, low and middle income countries. Usually that may not be the key commercial markets of interest for these pharmaceutical companies. And what that enables is, as I said, much faster than would typically be the case to have more affordable versions reaching the countries. And then, of course, you have to then work with all those other partners that really to make sure, okay, you have the treatment, but what about the diagnosis? What about the medical education? What about the training and all the infrastructure and health system needs that need to go hand in hand with it? But that's something that's been started off in HIV, worked really well, and it started being used across a range of different diseases. We've also partnered with Pfizer on the COVID antiviral to make ritonavir available from generic manufacturers across a lot of low and middle income countries. So it's a model that's really been started in HIV, but it's been replicated across the various diseases, and we're happy to work on cancer as well, of course.
Thank you.
So, new connections.
Yeah,
Isabel,
I
No, we are already connected.
Oh, yeah.
Let's say that at City Cancer Challenge we have what we call a readiness program for access to medicine. So we partner with
organizations like Direct Relief, and we would love to partner with MPP, where actually our role is not the medicine. Our role is, your role is to make sure the medicine gets to the country. Our role is to make sure that the medicine gets to the right patient at the right time. And that takes time, it's complex. So all these donations or pricing, it's great, but it has to come with health system strengthening investment. It cannot be isolated, because if not, the medicine will get and will stay, and I'm suffering some of, like, you know, how you say, when the medicine is out of date or things like that, because they're too fast. They want to send the medicine, but the system is not ready, so the medicine gets destroyed unnecessarily. So there is ways, and I agree, there is some complex cancer, but others, like breast cancer, that actually we know exactly all the steps to make sure that medicine gets. It takes us an average of 12 months to get the system ready for a set of drugs. Let us not forget that cancer is complex, and it's not just the medicine, it's also the radiotherapy, it's also the surgery, and diagnostic imaging, very, very complex. So I think that we can learn a lot from the communicable disease, but we're here is a big beast that we're addressing.
Okay, thank you so much for your excellent panel. For this panel, we are excited. And thank you also for your questions, your participation. I saw you were really very involved in that session. There's some hope. It's not so only so depressive from the where we started. We are depressed. We are now positive. And Jalid, you too? You are positive?
We are very engaged.
Yeah.
Now we are melancholic.
Thank you so much.
Thank you.